and we're glad to have you. Next slide, please. Just a note to anyone attending for the first time, or just a reminder, we usually have quite a few folks joining the call, so everyone's muted upon entry to avoid background noise. The call is always recorded, and you can find that recording on the Gravity Confluence page after the meeting. We do run a fairly active chat. I try to integrate any comments from the chat as I'm talking, Shirley, in order to have a conversation. And I appreciate the team helping with if I'm missing something. So please put any comments you have, direct them to everyone, and put them in the chat. And we also download the chat after to process what's been in there to make sure there's nothing to follow up on. So you also see as we go along links to pertinent information that we're talking about pop up in the chat as well. All right, next slide, please. This is a standard antitrust practices slide that we mention every single time. Next slide, please. Here we go. So if you've not already done so, the Gravity Project is only as strong as our membership, so we invite you all to officially join the project. The link is there. If you want to check out whether you've already signed up or if others from your organization have signed up, please review the existing membership on the Gravity Confluence site. It's quite large at this point. For any other Gravity information, you can visit the Confluence. It's a host of information. If you ever feel like you need help orienting, just write the Gravity team and we'll be helpful. We'll be sure to respond and try to help you out there. Next slide, please. We are incredibly grateful to our many different founders, grantors, and in-kind support folk to date. This list is growing, and we're just incredibly grateful for the collective. Next slide. Oh, there's a slide. If we might have missed a slide, or maybe I put it out of order. Eventually, you'll see a link to how to become a member. We'll show that eventually. So this is the agenda for the day. We're going to have some announcements. I always try to refresh and orient on our process these days because we have lots of new members on a regular basis. We'll discuss the schedule. There's some policy updates from both Mark and Evelyn. Bob will give an update on the recent FHIR Connectathon. And then I'm going to go into a host of end-to-end review topics on lots of our different domains, everything from financial strain to veteran status. And then we'll close with community homework and next steps. Again, throughout the call, please do submit any comments you have in the chat, and I'll be sure to address them. And throughout the talk, there are always pauses for questions if you have them as well. Next slide, please. Announcements. Next slide. There is a sponsorship slide. So the Gravity Project is currently seeking sponsors, as always, for 2021. If you're interested in learning more about sponsoring, you can send an email to the Gravity Project at emiadvisors.net or visit our Confluence site where we describe how to become a sponsor. Next slide, please. I'm going to just keep on talking unless Evelyn or Bob wants to pipe in. So this is our meta collective call that we have every other Thursday. There's a specific call that we invite everyone to attend regarding the technical work. And those calls are public and they're scheduled Wednesday from 3 to 4 Eastern time. You can access the calendar for through HL7 at the link that is just posted in the chat. So these are specific questions regarding the FHIR IG. It's a great time to go to those meetings after attending the Connectathon, because if you have questions or thoughts regarding the IG after testing and working through in the Connectathon, you will have an opportunity to discuss some of your thoughts at the meetings with Bob. Next slide, please. And then we talked about this last time. I don't know if Evelyn's on the call, so we do try to take care to announce fellowships that are offered through our many partners. It looks like Evelyn is here. Evelyn, do you want to speak to this?
Sure. Actually, I kept this. No, thank you. And I know Carrie Nicholson from NCQA was on last time and appreciated us announcing it. So it's just, we've had this on, but today is the last day because applications are due tomorrow. So it's really just encouraging those that are interested in fellowships to apply. If you haven't already with NCQA, that is one of our organizations we work closely with and is part of our strategic advisory committee, and we're very grateful for their guidance. So that's all. Just wanted to acknowledge lots of fellowship opportunities for in the area of health equity.
Thank you, Evelyn. All right, so those applications are due tomorrow, and the link is there. We did get a couple inquiries from Gravity colleagues and looking to try to fold in that work, and that was really exciting. Next slide, please. So we, as many of you know, we submitted an ICD-10 application on December 4th to the ICD-10 Coordination and Maintenance Committee of NCHS. You can view the submission at the Confluence. The submission's up for review in March. We do ask anyone if you want to send a letter of support, you can send those directly to the committee at the email. We are hoping to get them early just to make the case for a review at the March meeting. We did actually create a form letter at the request of the last meeting and the executive committee that will soon be available on the Confluence on the ICD-10 CM page. So if you wish to follow a form letter with standard content, you can do so. There are spaces for inserting your own case in order to make it not truly formulaic. So that will be available on the Confluence shortly. Next slide, please.
Sarah?
Hi. Hello, yes?
Can you hear me?
Yes, I can.
Could you go back to the previous slide for a second, please?
Yes.
Probably a number of people on this call have already sent in letters supporting the Gravity Project's letter. This new address, NCH SICD 10CM, that's an email address. Are you asking us to send those letters again to this address, or is this a different letter?
So Lucy, you're right to call out that Gravity has many different levels of involvement in different things. So we've asked so far for letters for USCDI. Yeah.
Okay. This is ICD-10.
Yes.
Sorry.
No, you're correct. I mean, and Lucy,
Gotcha.
I appreciate that if you have questions regarding this, you're not the only one, right? So we did collect letters for USCDI. We also collected comments for CMS request for information. So this is specifically regarding the ICD-10 CM application. And again, if it's a little overwhelming to find yourself in the sea of all these different things that we collectively engage in, the page that's posted in the Confluence has all the data, the specifics of like the application and the process. So next slide, please. This is such a fun thing. So our friends and founders, UCSF Siren, is hosting a new virtual conversation and podcast series. It's basically a forum for experts to discuss hot topics in health and social care integration. You can find the series at the link, and I'm honored to host one of those in March regarding updated approaches to risk stratification and social risk screening, which is something that you all know I talk a fair bit about. So you can find the podcast series at the link and the channel at the second link. Next slide, please. This is just, again, a quick update regarding the food insecurity press release, just up there for dissemination. Next slide, please. All right. We also want to just continually announce for any new individuals that we really are trying to make it very clear to kind of catch a wave midstream. Gravity's been going for quite a while now. So if you were a new member, it might be a little bit overwhelming to figure out who we are and what we do. So we have an educational and instructional materials section that details basically all the major coding standards. We also have new materials that detail basically a terminology orientation, and I did a video describing the adjudication process. Oh yeah, so Roberta's asking for the siren link. It got lost. It was above, so our amazing team has posted it again, just for the podcast series. All right, so this is that we really are trying to make sure our educational materials are robust, so that anyone can kind of spend a little bit of time catching up and orienting themselves to the work. Next slide, please. All right. This is just a grounding that we're going to be doing every single time. Next slide. Just a reminder of the 2 work streams of the Gravity Project. I principally discuss the work of terminology building, which is what we do. We kind of use this group as a sounding board for that work. And then Bob Dieterle leads the technical work in FHIR, and we communicate all throughout our initiatives, but specifically through referencing value sets that we collectively shape here in our public work in terminology, and then reference in the technical work through FHIR. Next slide, please. And just again, the goal is developing consensus-driven data standards to support use and exchange of social determinant of health data within the healthcare sectors and between the healthcare sector and other sectors, most notably the community. And as we say in Gravity, we might identify these concerns in clinical settings, but they're largely solved in the communities that we live and serve within. So those kind of relationships and connections are critical. You can see again that the domains we cover have expanded as we move beyond our initial charter here of just food insecurity, housing, and transportation. Next slide, please. This is just an iconography that you'll see throughout the talk about phases of our work. We're going to be doing a lot in the review section today. Again, we collectively identify concepts together, review them to create refined master sets. Then we vote on the sets to make sure that we all agree upon them with a consensus process. Then the team analyzes the set to figure out gaps between what we say needs to be said and what already exists. And then we collectively build code or work with our coding organizations to build those concepts into the coding standards. And then the next work is testing that and evaluating that, and that's in our pilot work to come this spring. Next slide, please. Just a reminder again of our use cases. The first use cases is documenting SDOH data in conjunction with the patient encounter, just simply taking care of the people who are right in front of us. The next one is documenting and tracking SDOH-related interventions to completion. This is the intersection with the community that we were just talking about. And for those of us who are in primary care, it's a critical patient-centered medical home element. So not just having ideas about solutions, but ensuring that we make sure those connections are being made to benefit our patients and clients. And then the last one is gathering and aggregating social determinant data for uses beyond the point of care. So things like population health management, quality reporting with our partners such as NCQA, and then risk adjustment or risk stratification. Corey's asking if these are listed in priority order. They are not listed in priority order. We often talk in Gravity about kind of like concentric rings. So they actually really just start with the discrete patient and clinician level, and then work out to community level, and then work out to population level. So they're more in the level of relationship order than they are in priority. I would say they're all important, equally important. And we, for instance, when I would say the intent and the understanding of each of these weaves through our specific focus to do any one, right? So as we were working in ICD-10 CM, you'll remember that we considered very intently and carefully the need to anticipate risk adjustment, and risk stratification. So even as we're working in one level, the needs of the 3 use cases are always at present in mind. Next slide, please. Or any other questions before we move on?
No, I just, this is Evelyn. I just want to clarify those 3 use cases are overarching ones, but they're the ones that you also see in the FHIR implementation guide. There's additional ones, so they're more granular, but it builds off those 3. So just want to ensure everyone, to Corey's question, that there is alignment between the general use cases and those out in the FHIR AG.
Evelyn, could you just say 1 sentence each? What are the use cases? Those 3?
Right. When Bob goes through his, he will show the framework and we'll show the additional 3, the breakup of these.
Thank you.
All right. So next slide, please. Do we have any more other questions? Are we good? All right. So this is the Gravity roadmap, which shows the intersection of the terminology work, the technical work, and our pilots to be. You can see the last time we had the call, we started to refine some of the real estate on the roadmap because as we endeavor to undertake domains, sometimes we actually slice the domains into multiple domains in order to address them. You can see interpersonal violence has been clarified on here. It was just actually interpersonal violence, you can see here, is still interpersonal violence, but we're clarifying it to be at first intimate partner violence and violence between elders. And we're making very clear to state that we're not addressing ACEs and child abuse at this time, because the goal of Gravity is to always make sure that we're doing things well. And so part of what we're doing in our work at all times is making sure we're carving out space and the experts we need to address domains carefully. You can also see we're heading in very swiftly into social isolation. We are considering moving stress to a later portion of the year in order to continue our work on material hardship that you will hear about very shortly. You also can see placeholders for the work of the neighborhood domains we've been talking about. So as we address food insecurity, we talked about community food access. And as we address housing, we were talking about neighborhood safety.
Can I just, I'm hearing background noise. If you are not speaking, please put yourself on mute. Thank you.
And as we were just housing, we planned and carved out space to talk about neighborhood safety. And this references, again, Corey, what we think about levels of work, right? So in this level of work, it's the person and their own personal experience first, and then the person in community next. So all of this work is work to come. And then you can see down below the technical work, the IG ballot has been submitted and the vote has happened. And we had our Connectathon just last week. And Bob will talk more about that work and the technical work on his presentation in a little bit. And then we are, again, like I said, looking forward to the piloting to come and looking forward to having you all collaborate. Our next big deadline for submissions is we are hoping to get as many of the screening question and answer elements in our domain set for an upcoming link submission soon. Oh, so Doug has a question that's probably best addressed by Bob. And Bob is presenting his section very shortly. So what I'm going to do, Doug, is hold space for that unless Bob wants to pipe up right now. Okay, so hold space for that, and then we'll have Bob come in talk in his section. So any other questions before we before we go on? All right, we have a lot of policy things to update on. So next slide. Oh yeah, so this is the calendar and the schedule. I forgot that this slide was here. So here we are in doing basically an all domain end-to-end review, specifically focusing on diagnoses and screening elements for education, unemployment, and veteran status. And then all of our activities from screening questions and answers, diagnoses, goals, and interventions for the rest. We still are aiming to have a vote on February 4th with some grace regarding that, just because we have a lot of work to do between now and then. And we're holding an extra session just to remind individuals on the 28th at the same time frame in order to ensure that we will be able to address these things well. So we look forward to seeing you at a special session next week. Next slide, please. Any questions on that? Basically overview stuff. All right, next slide. Policy updates. I pass the mic to my friends, Mark and Evelyn.
Evelyn, shall I go first?
Yes, you're first, Mark. Thanks.
Great. Thank you. So many of you have heard since we submitted on October 23rd about the Gravity Project's work to submit to ONC, Office of the National Coordinator, a new social determinant data class. We did submit it. Last week on the 12th, ONC released the draft version 2. Alas, the draft did not include the Gravity Project submission. And indeed, ONC proceeded on a fairly conservative and incremental approach, added just the 9 data elements that are listed there. Those 9 data elements, of course, are very important, but we were hoping to have the new social determinant data class as well. You've got a link on the slide in front of you if you want to read the draft version 2 that ONC released. And the ONC is taking public comments, so the comments are due on April 15th. The important message here is not including the Gravity Project social determinant data class does not in any way delay the community's groundbreaking work and advances, and those all remain on track. So all the work to standardize the terminology and the value sets and the representation in FHIR for nationwide exchange, the reference implementations, the community mapping, the pilots, all of that remains as scheduled. As we complete, it all remains available for national use. And what also remains true is ONC's classification of the submission as a level 2, which means ONC found that that our submission showed extensive existing use in systems, although not necessarily standardized the way, which is the important thing that Gravity is adding along with identifying gaps, that the use cases show significant value and that the data elements would clearly improve nationwide interoperability. So that was true before they released draft 2, it's still true now. So in short, it would be great, it would have been a great additional lever if the US CDI V2 had added the data class, but it doesn't delay anything. We're still moving forward and we can submit a new for version 3. Next slide, please. And I am seeing a question about when version 3 is. The announced plan was to do this annually so that you would expect to see the submissions for version 3 occurring in the fall of 2021, a decision by ONC by the end of 2021 about what's being released as a draft V3. We have had some conversations with ONC about the importance of including social determinants of health in US CDI, and they have reminded us that if there's good reason, they can also change that time frame so things could come earlier. I have not heard anything to suggest that they will. So I think that the regular time frame submitting in the fall of 2021 is probably what is best to expect.
Mark?
Yes, Lucy. Can I answer Corey Smith's question first?
Oh, please,
Which is
yes.
in the chat, and then I will turn to you.
Sure.
Corey's asking, will Gravity have to resubmit for V3? Whether or not we have to, it's a smart move to resubmit for V3, just to make sure that there's no confusion and that it's still on the table. Yes, Lucy.
Yeah, I was going to suggest that if anyone on the call has contacts with anyone in the new COVID-19 infrastructure that President Biden is putting together, I would suggest that that could be leverage to increase the probability that social determinants will be included next time, or that even a special process might take place to include that. I would speculate, and this is pure speculation, don't quote me, that a lot of the people being asked to participate in that new infrastructure are keenly aware of the importance of SDOH data, and failing to have it in USCDI would be something potentially for them to comment about. And I don't think that could hurt the next time we come up for review. I've already talked to someone on the committee that allegedly has influence with ONC on this subject, and the committee has not been informed of the rationale for leaving this out. So I immediately start thinking of leverage points within the new administration where people could start saying, why aren't these data in USCDI? We need them standardized. We need everybody reporting them. Thank you.
So I'll just say what Lucy said, as is often the case. Some of you may be so to Lucy's point, some of you may wonder whether the comment period is something to use as well. Yes, people could put in public comment asking that the social determinant data class be added in. Those comments again would be due by April 15th. As Lucy said, it cannot hurt. I'm not sure about the prospects for success, but this is important. And I will say that just going ahead and putting in a letter by April 15th builds the foundation. If it doesn't work for V2, it just continues to build the groundswell for version 3. What you have here, and with apologies for misspelling Codentix, if I'm even pronouncing that correctly, is a list of those who, the wonderful folks in the Gravity community has sent formal letters of support. Thank you so much. And we do know, because we heard directly in our conversations with ONC, that they were paying attention. So your work mattered. It did make a tremendous difference and gave plenty of visibility to the Gravity community's work. Next slide, please. Separately, CMS, Centers for Medicare and Medicaid Services, released a draft regulation which included some requests for information packaged with the draft regulation. One of those requests for information was about social risk data standards. The PMO worked over the holiday to draft a response to the 4 questions that were asked. You see a link to the letter there. We did file it on January 4th, 2021. The 4 questions were about current mechanisms, challenges, barriers, and strategies for standardizing and exchanging social risk data, which is everything that the Gravity Project is doing. So it was a great thing to respond to. Next slide, please. And wonderful to see many other organizations who are writing letters in response to that request for information, 31 at last count, also explicitly highlighted and supported the work you all are doing on the Gravity Project. So you see the list there. Again, an impressive list, and we keep the drumbeat going. Turn it over to you, Evelyn.
Thanks, Mark. Next slide. I'll try to go quickly. So just we had put this on our announcements and on our Confluence page. So for you who's not aware, CMS issued quietly on January 7th a new guidance for states on how they can use their federal match funding for Medicaid and CHIP to address social determinants of health. So the link there is at the bottom to the letter. Why this is important is because the letter actually states or encourages states to review the interoperability standard advisory, the ONC ISA SDOH standards that build off the work we're doing at Gravity. And it is the first policy that specifically calls out encourages states to participate and use the gravity identified standards. So this is a significant policy lever for this project. And we're super excited about it. So just want to make sure you're all aware. And if you are working with the Medicaid program, this is something for you to take a look at. The appendix actually does a really nice job of describing how you can incorporate SDOH in specific programs, waivers, and provides examples. Next slide. And so just to culminate, because we didn't get to do a year-end review with all of you. So I just, as Mark went through the policy updates, I want to acknowledge, I think at the beginning, last year, we had gone through our success factors, which we had identified, you know, basically, where do we want gravity to be in 5 years? Why are we doing what we're doing? What do we want to influence? So we had identified this at the within the gravity PMO and with our governance committees, is really, what did success look for the gravity project. So we identified these value areas. So today, again, in the interest of time, I just want to acknowledge that as Mark went through the US CDI, and then he talked about promoting interoperability, and then I talk about state Medicaid director letter, we all have to acknowledge we've done such tremendous work that we actually achieved this, right? So maybe we're not in V2 for US CDI, but we have enough, you know, so much engagement from the community at large. All those letters, all those organizations Mark just walked through, like that is significant, you know, to put a stamp on what we're doing. And of course, the work on the interoperability rule, the RFI was there to inform the next version of that or the next release. So again, we're there, and we've just made it into a state Medicaid director letter. So just want to acknowledge that. And for those just joining us and you hadn't seen this before, these are our value areas. We recognize that standards by themselves mean nothing unless they're incorporated in other activities, and what we call them policy. So it's more than just policy, payment models, programs, grants. I highlighted there the ACL Challenge Grant, which just closed 2 weeks ago. I'm in the process of reviewing all the submissions, almost 40 submissions. Again, that's an example where the grant incorporates the use of the standard. We have to do more work at the practice level, and we have to promote more innovation. So with that, I'll stop. Any questions? Okay, then back to you, Sarah.
Thank you so much, friends. It really is quite amazing how much has been accomplished in a year and a half. So we're now going to go into the next section of the call, which is specifically gleaning insight. I mean, any other questions on what Evelyn and Mark were presenting? All right, so we're now going to go into the review of the Connectathon with my colleague, Bob. Bob, are you on the call?
Yes, I am.
Wonderful. I pass the mic to Bob.
All right, thank you very much. Can we do the next slide, please? I want to remind everybody the scope of the implementation guide, the FHIR implementation guide. It includes all of the items that we are seeing here. It includes the ability to handle assessments and surveys and appropriately produce coded health concerns, which could be promoted to problems on a problem list. It includes support for goals. It includes support for interventions. Again, specific vocabularies for each of these. It includes the ability to go and do a referral to a community-based organization, and ultimately to go and get closed-loop feedback on the success of that referral. On the side, you'll see the ability to support consent of the individual to have information that's in a HIPAA-controlled environment released to a non-HIPAA-controlled environment, to a community-based organization, and the ability to go and do aggregation of data for the sake of reporting for any number of purposes, including quality management or reporting back to organizations that have responsibility for supporting the patients in various ways, including payers or community-based referral platforms. Next slide, please. You've seen this before. It's the approach we're taking to automating the survey instruments by taking the work that Sarah's doing and the community in link coding the question and answers on a survey tool. And this is not to say there's only going to be one survey instrument, but rather a process that any instrument could use to go and take those surveys, produce FHIR questionnaires, administer the questionnaires to an individual, to a patient, collect the information that comes out of it, and produce appropriate FHIR resources, the ones you're seeing here at the bottom, a questionnaire response and observation, a condition that can go into the process of evaluation between a patient and the practitioner to decide whether or not there are problems that need to be addressed. Next slide, please. So the implementation guide went into ballot, as Sarah had mentioned, as part of the January ballot cycle for HL7. It has completed the ballot as of the 18th of January, so this Monday. We had 226 ballot comments referencing all portions of the guide, from the way we describe the patient story to specific issues related to profiles. What we'll be doing is addressing those comments, those ballot comments, over the next probably 2 months. The call that Sarah mentioned on Wednesday, we'll use about 3/4 of that call to do what's called ballot reconciliation. It's where we go and get feedback from the participants as to the disposition of those comments, meaning what we're going to change, if anything, in the implementation guide based on the comment that individuals registered. We had 93 people that actually voted. 63 were affirmative votes. They voted in favor of the implementation guide moving on. 30 were negative votes, meaning they had submitted some kind of a negative comment. And those are comments that we will normally treat with a little bit more concern. The negative ones, the others are suggestions and comments and typos. But the goal is ultimately to go and ask them to withdraw their negatives. Now, because we hit the 60% threshold that's required to go and take a guide to publication as a standard for trial use, we're not reliant on anyone withdrawing their negatives to go the next step, assuming we determine that there is no reason to go back to ballot. Next slide, please. So this was the timeline that Sarah had talked about. We've done a little adjustment here. We started the reference implementation a little bit late because of the funding that we had received and the timing of it. We'll continue to go and build up that reference implementation and ultimately to update it and make it available for the May Connectathon, where we will go and test it in great detail, along with any others that have developed specific solutions based on the implementation guide. The goal is to get ready for the pilots. We show these starting here in May to June. Depending upon funding, we may start them somewhere between May and July. Next slide, please. This is what we had tested as interactions. The blue lines here, the connection between an EHR and a community-based referral organization in the middle, or a connection between or exchange of information between that same EHR platform and a community-based organization directly, or the ability to go and take aggregated information and exchange it with a stakeholder, in this case, responsible payer. So those blue lines with the circles around them are the things that we had tested on the exchanges. We also tested the ability to go and support the SDOH surveys, and we had a couple of people that were involved with that. We had 3 use cases we tested. Let's go to the next slide. I think that's a summary of our Connectathon. Okay, so this was the Connectathon track. It's available on Confluence. It has the information that we use to go and work with the participants. There were 25 that signed up. We had up to 35 on some of the calls. We had 3 use cases we were testing: the exchange and update of interventions between a provider and a CBRO or CBO, those blue lines that we talked about. Continued testing of the support for the risk surveys and the exchange of health concerns, problems, and interventions for a cohort of individuals, the aggregation capability, in this case, to report to a payer. There were 3 track leads: myself, Corey Smith from the AMA, and Monique Van Berkom also from the AMA. Next slide, please. These are some of the achievements. We were actually able to test the exchanges with the CBRO and CBO. We had Onyx played on one side and the reference implementation on the other. We had Z Omega, who played the role of the payer, retrieving information. We were able to demonstrate the concept of dynamic value sets. There was a question earlier as to what was going to be published as part of the implementation guide. The implementation guide is a framework implementation guide. It is intended to support any domain. The intent is to have those value sets managed externally to the implementation guide. So we don't have to go back to ballot every time we wind up with a new domain or a portion of a new domain that has gone through consensus balloting and approval for the value sets. So this becomes a way that we can turn around, and as you approve things, as this collaborative approves things, we can have them automatically made available to implementers of the implementation guide itself. We've validated again the work that we had done in September around the ability to go and create through mapping and structure maps the output resources that we talked about, the questionnaire response, the observations, and the condition resources to support health concerns. Next slide, please. We had a number of things that we learned as we went through this. There are some issues related to the overall use of what's called the task resource for coordination of exchanges. We have a method that we had selected. There are other work groups within HL7 and other tracks that are using the same tasks to coordinate activities. And there was some desire to make sure that we are using tasks the same way where the use case permits. What else do we want to talk about on here? We saw some obvious benefits in decoupling the questionnaire surveys, the logic needed to transform them from the implementation guide itself. There's some questions regarding how we interpret procedure using line codes and SNOMED. I think we're going to have to land that one fairly quickly. And we do understand we cannot get rid of complexity. It just gets moved around. Next slide, please. So what's next? We're going to continue to engage with NLM and Regenstrief and other stakeholders to advance the tooling to support the multi-domain support for the risk assessments and for the value sets. Engage in continue to develop the reference implementation, and then respond to the January 2021 ballot comments, as we mentioned, the 226. If you want to join us, come and join us on the Wednesday call for that, and for any to ask any questions and to get any guidance related to implementing the implementation guide itself. Next slide, please.
Bob, before you go to the next slide, could you comment, please, on the meaning and significance of, quote, externally maintained dynamic value sets, unquote? Externally maintained implies to me that there's a lot of optionality here. Am I understanding this? And if that's correct, then we're still going to have an interoperability issue, because anybody who is maintaining a dynamic value set can specify things as they please. So could you elaborate a little bit there?
Yeah, the intent is to maintain them within the construct of either Regenstrief and Loink or the VSAC supported by NLM. This is not something where everybody gets to maintain their own. There will absolutely be a structure to that. What it does is it stops us from publishing an implementation guide and locking down the value sets that are available to it, which is what typically happens. So this is the ability to make sure that as you complete these domains, as this collaborative completes the domains, that we can add them to things that are supported by the implementation guide. So the only increase in variability is the ability to support multiple domains. There's no ability that we're adding to go and create optionality around having multiple organizations do that. that answer your question?
Yeah, I guess when talking about this, both internally here in our group and externally, it might be good to make my question redundant, that the concept of externally maintained has an assumption or an inarticulate major premise, which is Loink and somebody is going to start to establish standardized sets to fit into the domain structure that the IG presents.
Actually, the work that Sarah's doing and the terminology work at Gravity will be establishing those value sets. We're creating a framework where they can be added dynamically to the implementation guide so we don't have to republish it.
Yeah, but we can do all we can to create standardized options, but we can't enforce them until they go into what you're talking about here, which is externally maintained sets that people have to use, right?
Well, these would be externally maintained sets that are referenced in the implementation guide. So if you want to be compliant with the implementation guide, and there is a standard that has been created by the terminology group here, you would need to use that to be compliant with the guide. So what we're doing is think of it this way. We don't lock down SNOMED. We don't lock down CPT. We don't lock down ICD-10 from continuing to add new codes and capability. We reference them and we externally maintain them. That's what SNOMED does. That's what we're doing is we're saying we're going to maintain the subset of those, meaning the value sets that are appropriate, externally to the HL7 implementation guide that is published.
Okay.
Okay, it gives us the flexibility to add new domains as we create the value sets for them.
No, I understand that perfectly well. I'm trying to understand the endpoint here. The endpoint is actual values that people are going to use and whether they're going to be standardized within the IG framework that we are presenting.
That's correct. They will be standardized within the IG framework we're creating. We're just allowing them to be added as they get created. Okay. See, do we have other questions that we should be addressing?
Yes, I have a.
Sure.
I was at the Connectathon and I saw that you had made a comment that there was a possibility. Hmm,
Sorry?
I'm looking for it. Okay, there's benefit of decoupling the development of questionnaire surveys and the logic needed to transform responses into conditions from the actual exchange structures in Gravity IG.
Yeah,
So
that's,
the
go ahead.
reason oh, go ahead.
No, that's fine. Please continue.
Yeah, my question is, there are so many differing levels of development of questionnaire surveys. There is the lag time of the Gravity Project recommendations, actual implementation of the guide for a particular survey. If someone has, since there is logic in the questionnaire model in FHIR for how to do this work inside Loink in particular, and someone's actually done that, there's still a possibility of then, let's say that's already done and it's not done necessarily. Yes, it's in Loink. Yes, the questionnaire there, but they've done the actual assigning of condition outside of Loink and they actually have those conditions. They can still come back in, you might say, into the FHIR and be able to utilize the rest of the recommendation as far as transmitting the data. I'm not sure if I'm explaining it correctly. I'm not an engineer. Does that make sense what I'm trying to ask?
I think I get your point. We're defining in the questionnaire process, the risk assessment process, the ability to use a standard definition as a LOINC survey and add to it the information that's necessary, the mapping, to create those observations and condition resources. So if you take your questionnaire and you go through the process of making a LOINC coded survey, and you follow the process that we're creating to go and be able to output the condition resource and the observations, then you'll have a standard path to go from a LOINC coded survey all the way through to the FHIR resources. That does not stop you from taking something that you have done separately that produces a condition resource and kind of dropping into the process. And that'll happen where EHR vendors have implemented particular survey process internally that has produced the observations and health concerns that didn't start with a LOINC coded survey. So there's going to be more than one way into the implementation guide at the front end. Is that what you're asking?
Yes, it is. And will there be visibility of how LOINC is actually in that process, or are they doing it in their tooling and using the FHIR model in their tooling to establish those conditions? Because if I go into LOINC and I look at a question answer survey and see all the codes to that, where do I see the actual assigning of conditions? Is that behind the scenes and it's only,
That's work we're
I mean, how
doing.
would we ever access?
That's
Oh,
work we're
okay.
doing with Reagan Street now, or we'll be doing over the next couple of months with them. And the reference implementation we're producing, which is open code and available to anyone, will be able to show you in code how that works. So
Oh,
yeah,
okay.
the solution is not here yet. We tested pieces of it in September. Some of it was manually crafted. We understand what we have to get done. We need to work with both Reagan Street, NLM, and ultimately with our reference implementation to make it real for everyone. Okay?
Thank you.
Yep, you're welcome. Good question. Is there published position from Gravity on incorporating SUH diagnosis codes and Medicare Advantage risk assessment models?
Bob, do you want me to take that one?
Yeah, why don't you go ahead? That'd be a great one for you to say.
No.
I'm going to hand this back over to someone who might be able to answer the question.
I know. Well, Bob, is that your last slide?
Can we go to the next slide? I think there's just one on the reference
Okay.
implementation. We've already talked about it, so go to the next slide, please, and I'll hand this back over to Sarah to answer this complex question.
Yeah, and I do want to specifically say that I'm really, really grateful for this conversation regarding the technical work. And I really want to encourage the same people who were just asking Bob about the Connectathon and the ID to attend that meeting on Wednesdays at 4 Eastern Standard Time at the link. Because that is a perfect venue to dive a little bit more deeply into some of these items. And I know Bob would love to keep on talking about these things as it's his areas of expertise. So please do follow that link as we had above, and you can always email us for information and attend those specific IG calls. Of course, the work is intersecting, hence we have a question here. So is there a public? Oh, yes.
Sarah, isn't it true that, or is it true that you have to belong to HL7 to participate in those Wednesday calls, or they are open to the public?
The Wednesday calls are open to the public. The only thing you have to be a member to do with HL7 is to actually attend their working group meetings or to vote on a ballot.
Gotcha.
Okay?
Thank you.
Yep, you're welcome.
It would be rude if I invited you to some place that you had to have no, I would never. Yeah, so it's public, and therefore it's a really great pairing of the work that we do across the project, but specifically regarding terminology in this meeting. And Lynn, is there a published position on Gravity on incorporating SDOH diagnoses codes in Medicare Advantage risk adjustment, HCC models, et cetera, et cetera? Not a published position per se. However, we are in constant collaboration with our colleagues at CMS and CMMI regarding perspectives on SDOH included in risk stratification. I imagine there might be a published position soon, but that is 100% something we're very passionate about advancing, especially as we understand how social determinants are a driver of risk and outcomes. So there's not a published position yet, but if you have a specific a place that you would like to employ some text regarding that and gravity's position, we'd be happy to receive an email and talk further about it. All right, we have a lot to do. And so, Edlin, I hope that answered your question. Anticipating risk stratification is part of everything that we do in collaboration with our federal colleagues. So, I'm now going to try to advance through a lot of content in the next 45 minutes. Although the call is sometimes the invitation just goes until the top of the hour. Sometimes we extend past, and I did do a note that we're going to try to keep on going. Okay, next slide, please. Just want to remind everybody as we segue from the technical work into the terminology work, what we do when we do the end-to-end review. There were a lot of new content data sets posted at the beginning of the week. So the Confluence now has updated information on many of our domains, and the work we have ahead of us, and again, it might need to stretch a bit, is to step back and look at the data sets that we're collectively creating and ask a few questions. We ask ourselves if there's concepts that are missing. Are there incorrect concepts that need to be changed? Are there concepts that are unnecessary and should be removed? I do want to call out that there's two areas of work that are still, the SMEs are still hemming and hawing over, and that's some of the program work we did earlier. So program work we still want submitted if you feel like it's not there, but there is a dump to be coming shortly. And then many of the expanded concepts within transportation insecurity, those will be coming shortly. The SMEs, we gave them an extended deadline and it was tomorrow. So you'll be seeing some updates on that next week. So the purpose of this work we do now is to basically discuss decisions we've made on those data sets and to ask the team to review what's there and help us make sure it feels full and correct. Next slide, please. Just some end-to-end review and inadequate housing elements, some stragglers. Next slide. I do want to state the last time we talked about doing an audit to make sure that critical HUD screening approaches aligning with our recommended diagnoses were included. So we did do that audit. We added the new questions. You can see them on the master from row 62 on. I've starred here some of the elements you can now see that were missing. So they might have been on some of our screeners, most notably the Naruzaman tool out of the Medical Legal Partnership from Connecticut. That's the tool you see on the Accountable Health Communities tool. But the HUD questions, again, in methodology are aligned with USDA's approaches to food insecurity screening. They're quite robust, and so we wanted to make sure that they were included. So you can see they are addressing infestations, mold, inability to store or prepare food, safety equipment. We do have a little bit of a typo here because lack of adequate water was updated, so you'll see that. And then that matches with some of the plumbing issues we've talked about before. We also have some updated questions regarding structural insufficiency. And then if you remember from the fall, we were going back and forth about how to represent when housing does not meet an inhabitant's functional needs. There are lots of beautiful questions regarding this in the HUD inadequate housing approach. And so these are part of the master now as well. So if one were to look at the master as it stands right now on the Confluence, you will see these updated questions, again, highlighting from row 62 on. We would love you to take a gander. Again, if the Confluence is ever overwhelming and you need an orientation, just email us and we're here to help. There's a lot of information there now because the project is quite complex. Next slide, please. Any questions regarding inadequate housing? Sarah, you spoke of assessing risk earlier. Will there be a focused discussion about the process of assigning risk during future meetings? I think we have, I think we can imagine that. I think right now, maybe we'll build that in an agenda going forward. We've been talking about risk throughout because when we assign diagnoses, And this was, again, part of our ICD-10 submission, a discussion regarding this. Whether or not to include like the terminology and concepts we included in our suggestions for diagnoses carry risk in the literature. So there are health risks associated with the concepts and conditions that we elected to include. This is the same approach as kind of the foundational work of doing HCC scoring. So again, assessing risk and claims and health outcomes, so diabetes with hyperglycemia carries more weight than diabetes uncomplicated, for example. So I think right now our methodology was mirroring existing methodology regarding what risk means for diagnoses. And I suppose if we want to have a specific conversation outside of that, I'm more than welcome. Maybe we can do it at the beginning. Maybe we can have that conversation after we finish this vote so that we can give time for the nuances of that. But at present, risk has always been assigned in conversations with subject matter experts through an understanding of the literature regarding the health outcomes associated with that condition. You can see that very principally in the work of housing instability, which was non-existent, and then concepts of housing instability that were critical for health risk in the literature were pulled out to be able to be used in assessment of risk and claims. Next slide, please. These are just our subject matter experts. Very, very grateful for all of their work, tireless. Next slide, please. Again, some transportation insecurity updates. Next slide. This is our definition of transportation insecurity. That has not changed at present. You can see that in the upcoming master. Next slide. Again, just to remind everybody, these are the current transportation insecurity screeners that you can see on the master. So again, in the questions we ask ourselves in end-to-end review, are there things missing? Are there things incorrect? Are there things that we need to remove? So these are the things that are there, the concepts that are there on the Confluence and the data set. We really encourage everybody to just look and make sure that you feel like it seems fit. We've gotten lots of wonderful suggestions recently from our colleagues at HighMark and FHIR. We're very, very grateful for all of them leaning in and helping us make sure that this work is complete. Next slide, please. Oh, great. So Carrie has some new screening questions about internet access from our health centers. We'll be getting to a domain that includes that concept anytime soon, very, very soon. So that has been folded into our work on material hardship as basically a necessary offshoot of the financial strain work. And we'll talk about that in a hot minute, just very close. Again, these are our diagnoses at present for transportation insecurity. This is unchanged from the last time we had a call. Next slide, please. So I do want to state very plainly that we do not, if you looked at the diagnoses, we don't necessarily have screening approaches for each transportation insecurity type. So if there's a critical diagnosis or critical type of transportation insecurity that's crucial for your work, if you feel like distance traveled, and I'm pulling that out of my hat here, is critical, but it's not currently represented, then, and if you have a standardized screening question that you utilize in practice toward that end, please submit it. We did get a lot of really wonderful questions from the transportation barriers measure that was added very recently because of the labor of some of our team. We're grateful for that. But one of the things that we do in our work is highlight areas that we know are critical, but we do not yet have necessarily screening questions to get there. Next slide, please. Are we considering screening instruments? Are we assessing the degree to which they could support automatic conversion to the gravity? Absolutely, Corey. So part of what Corey's asking, as we're considering screening instruments, are we assessing the degree to which they could support automated conversion to the gravity IG structure, or is this a downstream work item that will be considered later? So that question I actually just asked about questions and answers and diagnostic outcomes is directly linked to some of the methodology of the IG suggesting health concerns, because the health concern term will be a mirror of the problem or diagnoses term. So by highlighting gaps where perhaps we are suggesting a critical diagnosis, but don't yet have a screening question and answer that could suggest a health concern at the outcome, that's part of that consideration. So trying to weave anticipating the needs of the IG into our work and terminology development, again, not because the IG drives the work, but because we just, part of what we do is reveal gaps in terminology, but we also reveal gaps in screening questions and answers approaches or different elements across our work. So Corey, yes. Long answer, yes. These are some of the programs that we're working on with transportation. Right now, our SMEs are busy, again, defining all of these. We want to apologize because they're not on the master yet, but we do ask our subject matter experts to define anything that they're suggesting. So these are some of the programs that will be coming to the master again very shortly. But again, they have to be defined. And we're going to do a little bit of lift and support to help with that work because again, it's a heavy lift. So thank you again to our transportation SMEs. You guys are invaluable. Next slide, please. Any questions? So we've discussed some inadequate housing updates, some transportation insecurity updates. Again, this is to highlight the review period again, where Linda, myself, and the collective, we really are looking at those masters, assessing them as whole things, those master sets for each of the domains, and ensuring that everything is fit. And just a reminder, it's inadequate housing, transportation insecurity, and financial strain that we're looking to complete all the way from screening questions and answers to interventions at this time. And then focusing on screening questions and answers and diagnoses for a little bit with the other ones, just to give us a breath.
Sarah, I have a question which may be too far in left field. Recalling how many rural hospitals have closed recently and may continue to close, isn't it true that our transportation concept thinking is all ground-based? Is there any reason for us to have to think about or even just nod to air or water transport as something that, say, a lot of patients using a particular clinic might need on a relatively regular basis?
So I think if you actually looked at the screening questions and answers, I mean, again, I put a car there in the cloud icon for you, Lucy. But if I were to review the actual screening questions and answers and diagnoses, none of them talk specifically about wheels, or very few do.
Okay.
Almost all of them talk about transportation as a general concept. Like,
Right.
do you have a hard time getting to, right?
Okay.
And so, no, I think it's actually really important, though. I 100% am a rural practitioner. So, and I think it's important to understand that there are some of our programs, of course, that will be specific to modes of travel. Like in our programs, we talk about car shares. We talk about, gas card vouchers. We talk about public transportation vouchers. But what I will ensure is, I know right now the approaches to and the diagnostic outcomes are agnostic to the means or the method of travel. I will take a look at the programs to make sure that that we are carrying that through to that area, though. Thanks for the note to self, literally. Okay.
That's great. I think it's really important when we talk at strategic levels about how Gravity thinks about social domains that we're very aware of rural America and how its needs may differ well, urban and rural America, how their needs may differ, and in particular with respect to transportation. Thank you.
Yeah, and I think, you know, in the conversations we've had with the subject matter experts, we've even been really careful to talk about modalities, right? Because we are, you know, as we think about the individual lens and the community lens, you know, we talk about things like sidewalks. You know, in our conversations, it's definitely not just about vehicles. It's about
Okay.
yeah. So, but I'm always grateful for you thinking and naming the thing that needs to be said. So,
In
100%.
the definition of transportation, you use the word affordable.
Mhm.
And when we're talking, at least when I'm thinking about helicopters or air transport, that's not affordable from a patient point of view. So affordable from a system point of view, I mean, that really gets into deep policy issues. So
Yeah, you know, and just I think you know, I think one of the things that you can see this like actually in the work across our domains, this is partly why we break things down into parts, right? So I might be able to make a, a patient have a quicker travel to their clinic by giving them a helicopter ride, you know, a helicopter taxi through Medicaid or something. But that does not solve the affordability question. So the moment you say transportation secure as a meta concept, it includes all of its things, right? So we have to be careful to think about what we're aiming for and what we're intervening on and what we're able to solve without falsely claiming we're solving everything. So we do have these concepts when we're talking about these as well.
thank you.
So as the healthcare environment changes to a national system of looking for best rates of treatments, other methods of travel are needed. Yes, yeah, and then we also talk about our environmental element output. You know, Lucy raised this as well. I think last time that we can't neglect to talk about the environmental footprint. Yes, all of these things. Wonderful call as usual. Any other questions on that bit? All right, next slide, please. Financial insecurity updates. Next slide. All right, so I wanted to give a little updated note that I think I might have been a little bit misleading when I presented this last time. So our initial domain that we discussed when we started this work was financial strain. And then when the SMEs dug in, as I mentioned on the call, they broke it out into two different concepts, financial insecurity and material hardship. I made the line from financial strain to material hardship into a dotted line because from a parent-child relationship, you know, what's true of the child has to be true of the parent, and that material hardship is not always related to financial drivers. So it's by making it a straight line, I think I convinced everybody that we were talking about financially driven material hardship alone, and that is not what we're doing. So I want to clarify that. So you can see, again, Carrie, we're talking about internet and connectivity. So this is the reference to what you were mentioning there is critical for the work of clinics all over right now as we adjust to the pandemic, connectivity and inability to obtain internet. At present right now, the subject matter experts and I are thinking about differentiating it. Exactly, Carrie. Of course, you anticipated it. Differentiating into inability to obtain internet and then secondary too. So because it doesn't exist in the environment or because I'm unable to afford it. Yeah, so how are you considering ability to afford a data plan that goes with internet? I think that would be included in inability to afford. Because again, we have to think about part of what we do with Gravity is kind of like make initial attempts at kind of organizing the wilderness. And then we want to be careful to test those initial attempts before we get things more further granular. And one of the things I think that we think about when we think about dicing things up is interventions, right? So if the intervention is about cost, that's one thing. If the intervention is about community broadband, as it is in Vermont, that's another. So I made this a dotted line just to kind of separate that. So Tom's asking, will there be any kind of cross-reference to material hardship specific to other domains, e.g. food insecurity, homelessness, et cetera? So that's something that we're very cognizant of. So certainly, I'm actually going to ask the next slide to come. Next slide here. Oh, these are definitions of financial insecurity and material hardship. Next slide. So the way these two things overlay, and Tom, this was actually in reference to your question. So the other domains that we've talked about so far are very much an entire thing that lie from kind of the left of this Venn diagram through the point where they overlay. So when we talk about food insecurity in the US, our methodology, it's all driven by income according to the USDA gold standard tool. So we do consider how each of those other domains that we've already talked about relate to the concepts that we're covering in financial insecurity and material hardship, because they aren't necessarily intertwined. And I think I probably just need to do a logic model that shows all of that together. Right now, we're only talking about the things that we haven't talked about yet. And these are some of the most vague, right? And so we do consider food insecurity, housing instability, homelessness, transportation insecurity as laying as concepts within this Venn diagram, within financial insecurity and in the overlap between financial insecurity and material hardship. But we're specifically right now trying to talk about the areas we haven't talked about yet, like data, connectivity, childcare, clothing, basic essential needs. Tom, was that a good enough answer to your question? I'm hoping. Yes, thank you. Okay, good. Is inability to obtain interchangeable with maintain? Mary Ellen Rose, that is a very, very good question as we consider stability. So again, when we think about the screening methodology for these things, a really good example, for example, is a repair tool is like, have you been unable to get this, right? So part of what Gravity reveals is areas for psychometric study and developing more refined tools to address these kinds of things. So certainly financial insecurity includes concepts of stability. Right now, I do not know of any of the tools and questions that we use to address these kind of more simple elements of absence, talking about stability, except for some in the data equity space. But that's something that we'll certainly talk about. Again, material hardship is a concept that we created in our work towards financial strain. We will deal with it on its own, but we talk about it right now because it came up as we were doing financial strain. Yeah, so Tom is, yes. So right now we're talking about, do I have it? And then whether or not it's stable is another question. But the reason why I think it's interesting here is stability is a critical element of some of the more sophisticated screening methodology of things like the USDA food security module, for example, or the US housing security module. So domains that are a little bit more developed in their assessment approach do include stability approaches. All right, next slide, please.
Sarah?
Hi, yeah?
I'm really trying to get my head around the concept of material hardship, was it, in the previous slide?
Yeah.
And if you think about it, when patients present and we want to understand the social dimensions of their health, to me, that is really different from lack of social infrastructure like broadband. Unless the healthcare sector wants to be able to identify infrastructure gaps that affect health, because the interventions for infrastructure gaps are political. They have nothing, at least I'm just thinking out loud here, there's nothing a clinician can do for an individual patient about lack of broadband in a section of Vermont. So I'm wondering about the concept of material hardship, how we can get at that within the gravity framework, which is very patient-centered.
So I guess I hear you, Lucy, but so I have two responses. So I don't see the community absence of, I don't see data equity as any different on a community level than community food access or community transportation security or community food security in the broadest sense. And we do talk about, from an accountable health community perspective, how the health system cannot address the needs of the individual without addressing the drivers or upstream causes in the community. So I feel like it's actually very much within Gravity's work to consider community level concerns and community level solutions. I think it might,
As long as we're clear that we're talking about community level solutions and not, quote, clinical solutions. I'm thinking about food deserts, for example. The concept of food desert came out of everyone dealing with patients recognizing that you had to take 3 buses to get to a decent food store because liquor stores don't sell food. So that's been going on for such a long time, but it could not be resolved at a clinic level. So everybody got together and said, we need to do something at a municipal level about food deserts. And lo and behold, the health department started to do that. So I guess I'm trying to incorporate that sequence. So yes, I'm agreeing with everything you just said. If gravity if it's within the scope of gravity to understand that community level solutions are essential for patient care, great. I just wanted to make a distinction because the nature of the interventions are very different from my point of view.
yeah, and I think that's what I was trying to reference regarding the due to statement I made on material hardship, and I'm sorry I wasn't clear there. So if we are going to be clear about where we go next, saying it's related to the person not having enough money to pay their internet bill is a different intervention than saying it's present because it doesn't exist, right?
Exactly.
And that's
yes.
Yeah. But I do want to state health systems themselves, right, in collaboration with municipalities, have been doing community level interventions for a long time, whether it be regarding housing or
Yes.
groceries, or so that is. I mean, again, in the grand scope of complicated U.S. health policy, hospitals have learned that in order to prevent readmissions, they need to buy housing for post-discharge housing for their individuals who are experiencing homelessness, right? So there's and that's partly why we imagine this neighborhood and community section of our work coming, and it is not their element of data equity would be best addressed then. But we've crafted space for it now because of addressing the I can't pay for it bit.
Okay, great. I agree with all the comments. I think all the comments coming about this conversation are all terrific. Okay, thank you.
I love it. And then one more thing, I think you can also imagine when there's enough pings of concerns within individual instances from a population health approach, that's where use case 3 comes in, right? Aggregating data and identifying hotspots and doing community interventions that way.
Material hardship is the basis for population health, or a basis.
Yes.
That's where you start.
Yes, it's one. Yes. Well, it's one of the. Okay, so now I'm committed to actually making the map that Tom suggested that I needed to do. So, because coming soon again is the refinement of our work together. Next slide, please. So Carrie, in the sense that there will be a place where these overlap when a majority of people can, Tom, that sounds wonderful. Majority of people can afford something even if it doesn't exist. Oh, yes. So yeah. Carrie, that's a good statement. In a sense, there will be a place where these overlap when a majority of people can't afford something, even if it does exist. Even the opposite, when a majority of people can afford it and it doesn't exist. Some examples would be housing or places where there's only one internet provider. Exactly. Okay. Wonderful conversation as always. I think we collectively make what we're trying to do clear every day. Just a brief overview of financial insecurity material hardship screening tools. We only have 5 more minutes, so I'm going to try to keep on going. I want to get to, this is all the end-to-end review elements. So if folks can go to the website, the Confluence, and review the masters, that'd be great. Next slide. We were just talking about this. So one of the things we're thinking about is how to clarify cause of hardship, financial versus lack of resource. And so that's coming soon. And the reason why it's a little bit complicated is, if you'll remember, we're bound in ICD-10 CM by the absence of the problems of physical and environment category that we advocated for a return in our application. So all of these concepts we're talking about, like it does not exist, would be best in that Z58 physical environment tree. So if you want to specifically just mention that in the letter, that's great. I did include that in the form letter. Like, this is why this needs to happen. Yes, the cardio study question that's included in the IOM instruments in the financial strain section. It's kind of the heart of the financial strain approach, 100%. Cardio screen is just one of the gold standards there. All right, next slide, please. Any questions? My lord, so many questions. I think we've addressed them so far. Next slide. Just quickly going through these last bits before the end of our call. Next slide. Again, we're just truing everything up, making sure that we definitely include all of our federal approaches in our screening questions and answers. Again, these ones we're focusing principally on screening questions and answers and diagnoses. Next slide, please. So these are our current education, unemployment, and veteran status screening approaches. Leaning on with the VA Community Provider Toolkit, which is a helpful approach. In the education, you can see elements from AAFP, Children's Health Watch, FNX. What's not there is the U.S. Census approach. You will see that come very shortly, which is just the core of all the U.S. screeners, whether it be the census, whether it be the current population survey, whether it be the HUD housing tools, whether it be the USDA tools. So that's coming soon as well. We just elevated that this week. Next slide, please. I just wanted to let some folks know that some of the questions we're hemming and hawing on, some questions that were submitted were like, do you need help getting more education? It doesn't necessarily mean that you have less than a high school degree. So this is where screening methodology can be a little bit tricky. Some of the tools that we have in this space ask just about, do you want help with? The We Care tool is an excellent example of that. But it doesn't necessarily assess the absence. So again, with an unemployed looking for a job, doesn't necessarily mean that you're unemployed. You could be looking for a job and underemployed or unhappily employed. So these are some of the things we're hashing out. And then one of the things we're thinking about as well is, have you been discharged from the armed forces as a veteran screening tool? Just about the use case for that specific tool question. We've reached out to the VA on that one. Okay, so I only include these because it's important for you guys to know some of the questions we have to ask when we're thinking about building the master set. Next slide, please. Okay. Does unemployed include unemployed with supplemental benefits or not? So current methodology is just if you do not have a job. So if you mean unemployed on SSI, if that's your meaning, or monetary supports, that would be included, yes. There's a separate category for disability though. which I guess I brought up SSI, so now I'm going to walk back on that. That's a different category within at least the US Census approach. Next slide, please. Whew, I think it's 5:29. I'm going to try to talk briefly about goals before we go home. Oh, it's 5:30. Okay, quickly. Next slide. I just want to briefly call out a comment I got in an email that I think is really important from a very patient person we've been trying to meet. About the interplay between social risk and protective factors. I just want to state very clearly, the opposite of risk is not always the presence of a protective factor. A very kind person who's a math person who was talking with me about that matter via email, and I 100% agree. So next slide. Simply naming a protective factor or a positive thing as a goal does not mean that if you did not have the problem, that protective factor is true for you. So this is just some work we're doing and trying to figure out this whole goals and protective factors work. So on the top, you can see basically the structure of how we work in goal setting, leaning heavily on the publications of NCQA and elements like and organizations like the Camden Coalition. So one of the ways we've been talking is about what can be standardized. So we do know in our work, and again, I might have to say this for next time just because I don't want to take everybody too long, but I'm going to say just one final thing and you guys can think about it and look at it on the Confluence or write me. We're thinking maybe that we can standardize the kind of meta goals or overarching goal, but still allow for patient-specific actionable measure goals through a SMART goal process for those intersteps. So you can imagine with inadequate housing, for example, if your problem with substandard housing due to inability to prepare or store food, your meta goal or your protective factor or the positive statement might be that housing has resources for food preparation and storage. But the SMART goal, the actionable goal, the thing that you're working on, it might be fixed stove with repair voucher, right? So again, it'd be hard to develop terminology for every SMART actionable goal because they're unique to the person and the resources, but you can imagine how that would feed to a meta goal. So these, again, talking with our patient care work group folks, if you ever want to have a goals conversation with me, please email me. I think about these things all the time because because I do. All right, next slide. I'm going to keep on going. So it just reiterates what we were talking about in the previous slide. Next slide. Okay, next slide. Homework. Now, next slide. Amazing, Sarah. Okay, so review the master lists. They are on the Confluence. We just highlighted some of the changes. Come back next week. So usually we don't meet for 2 weeks. Next week we're having a call to further talk about these elements end-to-end review. There will be a lot of updates in between now and then regarding programs coming, transportation insecurity diagnoses, financial strain diagnoses, and material hardship diagnoses. Again, material hardship's kind of holding space for it, again, focusing on it in a little bit, but we are thinking about them at the same time because our subject matter experts are experts in both. And then, we'll see you again next week. I think next slide, just making sure there's no more homework. Oh, join the Gravity Project. Thank you for coming along with me in 45 minutes of rapid fire terminology work. You are always so lovely. And then Lucy, I'm going to go look at our programs for transportation insecurity to make sure they include additional methods of transportation.
Thank you, Sarah, for everything.
You guys are all wonderful. You have a lovely Thursday night, and we will see you next week.
Thank you. Bye.
Bye.
Thanks, everyone.